So research to practice, June 25th, Jeffrey Aldrich, MD, updates on the management of early and metastatic breast cancer. And we've got that. Feel free to read that, but we're going to focus on the top 5 here. Dr. Aldrich, welcome. We're so glad to have you here today.
Thanks for having me.
Absolutely. So, MD, medical oncologist at the UNC Chapel Hill, focusing on treating patients with breast cancer. And in 2016, received your medical degree at Jefferson Medical College in Philadelphia. And in 2019, completed internal medicine residency at Baylor College of Medicine in Houston. After that, you were at MD Anderson for 1 year doing research on incidence and management of immunotherapy-related adverse events. And 2023 completed medical oncology and hematology fellowship at Emory in Atlanta and started on faculty at UNC almost 2 years ago. Mm-hmm. And finally focused on clinical care of breast cancer patients and also enjoys collaborating with researchers and teaching trainees. Excellent. What's something we should know outside of your professional bio?
We were just talking about this earlier. Yeah. We are about 7 weeks from the birth of our second son, so that's been an exciting month and a half.
Yeah, really exciting. Good for you.
Thanks.
Yeah. Any coordinated napping going on yet?
Well, I was off for the month of May, so it was a great time to kind of get caught up on some of that, but good to be back.
Good. Well, let's see. We've got our poll everywhere question. Metastatic breast cancer is breast cancer that is spread to another part of the body. As usual, this is a softball. And go ahead and, again, anonymously let us know, do you think that's true or false? I don't think we need to spend a lot of time on this. I'm assuming they're doing all right with this one.
Looking good.
Great. Well, I'm going to move it to that slide and then pass you the keyboard and mouse. So. Right.
Well, thank you very much for that introduction, and it's great to be here today. Let's get started. I don't have any disclosures relevant to the talk today. First, just go over some learning objectives. So we will review some of the recent drug approvals for the management of breast cancer. We will then talk about some results of practice-changing clinical trials. And then the last section, a little bit different than the first two, we're going to talk about the management of GU symptoms of menopause in patients with a history of breast cancer. And for anybody who sees breast cancer patients knows that this is a common topic that comes up. So we'll review some aspects of caring for these patients. And just to kind of break it down a little bit more, we'll focus first on early stage breast cancer and go through some of the subtypes and management changes. And then we'll also review metastatic breast cancer. And one thing to highlight is we'll talk about a case and also the newer class of treatments, antibody drug conjugates or ADCs, that are growing in the prevalence for the management of breast cancer and also other cancers as well. And then the last part about the GU symptoms of menopause. So to start things off, let's do a question. So we have a 60-year-old female. She has a history of a right, stage 2, grade 3, elevated oncotype of 26, hormone receptor positive, HER2 negative breast cancer. She's been through her local regional therapy as well as chemotherapy. She has now been on adjuvant aromatase inhibitor for 2 months and is tolerating it overall well. And so the next... Was that too soon? Let's see. So the next question basically is, at this point in her care, which, if any, of these medications would you add to her adjuvant endocrine therapy? So first one is palbociclib. The second one is abemaciclib, elacestrant, ribociclib, or the last choice is I would not add any additional agents. So we can give a couple minutes. So, there we are. And so basically this is a question that highlights the use of an adjuvant CDK4/6 inhibitor. There are 2 approved in this area, in this space, and that is abemaciclib and ribociclib. So both of those would be correct answers, and we'll talk a little bit about, those 2 agents and how we decide to use one versus the other. Okay. So the first study that I'd like to talk about is the Monarch-E trial. This was specifically a study looking at the use of adjuvant abemaciclib in a high-risk cohort of early-stage hormone receptor-positive patients. The schema here kind of highlights the inclusion criteria. So there were 2 cohorts on this study. Patients had to have 4 or greater axillary lymph nodes involved with the cancer, or they could have 1 to 3 lymph nodes involved, so N1 disease, as well as a high-risk feature, and that was either a grade 3 or a large tumor, 5 centimeters or greater. There was also a second cohort on this study that had 1 to 3 lymph nodes involved and a high-risk feature of Ki-67 being 20% or greater. They were randomized to receive standard of care endocrine therapy with or without abemaciclib dosed at 150 milligrams twice a day for 2 years. This was initially approved in 2021, and the initial FDA approval did require the Ki-67 to be 20% or greater, but in 2023, this was updated and the requirement of the Ki-67 was taken out of the approval. Okay. So in talking about the benefits and the efficacy of this drug, so in 2023, the 5-year data was presented at a European oncology meeting, and the manuscript was published just last year. And so what we're seeing over time is the widening of the curves when it comes to invasive disease-free survival. So the most recent update is at the 5-year mark, and you can see that the absolute benefit between the 2 groups was around 7.6%. So what we can see over the years of follow-up is that the benefit is actually increasing. And so at the 5-year mark, about a 7.6% absolute benefit. In the latest update, statistical significance was not yet reached for overall survival. And importantly, talking about the side effects associated with this medication, I highlighted a few here. We do think a lot about diarrhea. So overall diarrhea occurred in about 80% of patients, and severe grade 3 or greater happened in about 7.5% of patients. Additional adverse events to kind of remember are much more rare, but can be life-threatening, and that includes interstitial lung disease, liver toxicity, and venous thromboembolism. It's kind of important to note that specifically when it comes to VTE, while this was rare, less than 2% of the time, when abema was combined with tamoxifen, it rose to 4%. So there was an ASCO rapid update about this since the data was published, highlighting that risk. And this is an important point to remember when prescribing abemaciclib, is to consider a patient when thinking about combining with tamoxifen because of the elevated VTE risk. So when possible, we do prefer to combine with an aromatase inhibitor. Also important to remember here is that the discontinuation rate of abemaciclib was about 25%. It was 25% of patients on the study had to discontinue early, almost 20% due to adverse events, and over 40% required a dose reduction. And anyone who's prescribed this medicine or managed patients on it definitely can relate to that experience, I'm sure. So this is some late-breaking news from the ASCO meeting that was earlier in the month. This was a very interesting trial. It was a prospective small study that actually looked at a dose escalation of abemaciclib. Instead of starting at 150 milligrams, this trial enrolled about 90 patients and did a dose escalation. So they started at 50 milligrams twice a day for 2 weeks, then they went to 100 for 2 weeks, and then got up to the 150 milligram dose. The endpoint that they were looking at was this composite rate of discontinuation for any reason, or if patients weren't able to reach or maintain the 150 milligram dose. And I think the takeaway from it, while we don't have any longer than the 12-week follow-up data, it does look like about 70% were able to reach and maintain the top-line dose at 12 weeks, which is better than what we saw in Monarch-E. So while we do want to see kind of longer follow-up from this, this is a pretty straightforward, easy escalation strategy that may have benefit in terms of reducing the amount of side effects from abemaciclib. And we've seen that with other oral cancer-directed drugs before. And to pivot over to the other CDK4/6 inhibitor that is approved for adjuvant use in hormone receptor positive breast cancer, we're looking at here the NATALEE study. And this looked at ribociclib. And you can see here some important things to note are the inclusion criteria, which are different than abemaciclib, and also the length of therapy. So patients here were treated with ribociclib at 400 milligrams, which is different than its metastatic approval at 600. And they were treated for 3 weeks on, 1 week off for 3 years, in addition to their standard endocrine therapy. So it was comparing with or without ribociclib for 3 years. Important to note about the inclusion is that patients who were node negative were eligible if they had other high-risk features. That's in contrast to abemaciclib, which was only studied in the lymph node positive patient population. And so that's important when thinking about which patients may be eligible for which drug. In terms of benefit, so the initial publication for ribociclib was at ASCO 2023, and that was 3-year efficacy data. So for the whole intention to treat population, the invasive disease-free survival absolute benefit was around 3% at 3 years. Similarly to abemaciclib, we don't have mature overall survival data, which we would expect to take quite a long time given the natural history of this cancer. And then here's an important update that was at the European Oncology meeting last year. This was an exploratory 4-year landmark data that was presented. And at this point in the follow-up of the adjuvant ribociclib patients on NATALEE, there was a median follow-up of about 44 months, and no patients had remained on ribo at that time. So everybody had finished at that point, and we are seeing a deepening IDFS benefit. So at 4 years, there was about a 5% IDFS benefit, up from 3% at 3 years. And they did break it down a little bit, so we can see some subgroups here. And specifically, what I was kind of keen on looking at is the node-negative patients, because we're really trying to see which groups within the intention to treat population are benefiting. And it does appear that even with node-negative patients, there is still about a 5% benefit, so similar to the overall intention to treat population. And the node-negative population was around 28% of patients on that study. Importantly to note side effects from ribociclib. So when thinking about grade 3 events, so very commonly we are seeing neutropenia, which is a known risk of this drug. Fortunately, we are not seeing much incidence of febrile neutropenia, so typically the neutropenia is asymptomatic. We are seeing, however, about a 6% rate of grade 3 liver AST and ALT elevation, so this is an important side effect to consider when starting this medication. Also rare with ribociclib is interstitial lung disease, less than 2% of the time, and also less than 2% of the time are we seeing venous thromboembolic events. One also caveat to note here is that tamoxifen was not permitted on the NATALEE study, so we typically do not favor combining tamoxifen with ribociclib. The main concern here was the increased risk of QTc prolongation that was seen in the metastatic ribo trials. The caveat here, though, is it is something that we can watch and observe. So we do get baseline EKGs for these patients before we start and then after starting. And the previous data looking at combining tamoxifen with ribociclib was looking at the higher dose, and we do think that this is a dose related effect. So not an absolute contraindication, but important to note that it was not studied in combination on the NATALEE trial. This is a chart here that I always try to refer to when I'm thinking about both of these medications and who might be eligible for which one. This highlights the differences in the criteria in terms of which patients are eligible for which drug. You can see on the left-hand side the NATALEE study, and you can see much greater numbers of patients that were eligible, including node-negative patients.
May I interject a quick question? So I think, if I'm remembering correctly, that on the poll, there was a strong preference for ribociclib over abemaciclib. Any idea? I didn't take that away from what you just said.
Mm-hmm. So that's a good point. I would say in my practice, I became an attending August of 2023. So we already had the ribociclib approval at that point. So
Okay.
in my experience, I have usually leaned more towards ribociclib, just given the tolerability that we see in the real world practice. But I will say that it's important to kind of individualize the decision. There's not necessarily a right or wrong.
Sure.
The possibility of doing 2 years versus 3 is an important one to consider depending on patient preference. And also, comorbidities, drug-drug interactions. I do think a lot about diarrhea in abemaciclib, and I think a lot about liver toxicity, especially with ribociclib. So not necessarily a right or wrong for that patient. And I think the next slide we had the poll question again, just to see if anybody changed their decision.
Yeah.
But based on these two approvals, both would be possible right answers.
Gotcha. Thank you.
So we can maybe just do the poll question again and see if the distribution has changed, if anybody has a different opinion. So it still looks like about 70% of people are saying ribociclib.
Interesting.
Okay. So next, I'd like to shift gears and talk about updates in early stage HER2 positive breast cancer. This is the Catherine trial, which many people may be pretty familiar with because it has been the standard of care for quite some time now. But just to recap the inclusion for the Catherine study, these are HER2 positive early stage patients who had residual disease in the breast or lymph node after neoadjuvant chemo and HER2 directed therapy. And they were randomized to receive trastuzumab emtansine or TDM1 or Kadcyla for 14 cycles versus continuing on trastuzumab for 14 cycles. And the latest update for this study has been done recently and presented, and it's important to see here that now at the 7-year IDFS follow-up, the benefit has now expanded to 13% in terms of an absolute difference between the two groups. And then we can see here, very important to note, at 7 years, a 4.7% absolute overall survival benefit with being on adjuvant TDM1. So also in this update in the New England Journal, there were no new safety signals. So the adverse events and side effects were consistent with what was known about TDM1 before. And the main takeaway here is that this certainly does remain the standard of care in this patient population, and the updated data reinforce that. And then I'd like to talk a little bit about triple negative breast cancer and the updates in the early stage setting. This is the Keynote 522 trial, which has new overall survival data that was presented last year and published in the New England Journal at the end of last year. So just to recap, the Keynote 522 regimen is multi-agent chemotherapy with or without pembrolizumab, and that is now the standard of care with the pembrolizumab for stage 2 or greater triple negative breast cancer. Primary endpoints were pathologic complete response rates and event-free survival. This has been approved since 2021. This update is specifically looking at the overall survival. So you can see here that the updated time at 60 months, there is now a reported absolute difference of around 5% in overall survival between these two groups. So certainly this is the standard of care in 2025. And the next thing I'd like to do is highlight a few open clinical trials that we have here at UNC Chapel Hill. So anytime, if any of these trials you're thinking about a patient that may be eligible for, please always feel free to reach out to me and we can get the patient in to kind of be evaluated further. But this is the first one to talk about is called the ASCENT-5 or the Optimize RD, the RD standing for residual disease. So if a patient has received neoadjuvant chemo with or without immunotherapy and do not receive a PCR at the time of surgery, this is a good option to escalate their therapy in the adjuvant setting. And so this trial adds sacituzumab govitecan, which is a drug that we'll talk about in a little bit, and that's added to the standard of care pembrolizumab, and that's being compared to the standard of care pembrolizumab with or without standard of care capecitabine. This is another adjuvant study in the same patient population. So kind of the flip side, if a patient does have a PCR, so no evidence of cancer at the time of surgery, this is an option for them. And what this is doing is randomizing patients to continue the standard of care, pembrolizumab, for 27 weeks versus observation. And the hypothesis of this study is that if a patient does experience a PCR at the time of surgery, that they're unlikely to benefit from further pembrolizumab. We don't know the answer to that question because on Keynote 522, all patients received the adjuvant pembrolizumab. So this is an important study, and certainly a benefit of not receiving further pembro is, there are less exposure to the drug, so potentially less side effects, which we are still seeing in the adjuvant period. And just as we're trying to utilize the PCR status in the adjuvant setting to help us decide how to escalate or de-escalate therapy, this is a study that's actually looking at the neoadjuvant setting. So instead of using the Keynote 522 regimen, can we use a different, potentially less toxic regimen and have the same outcome, which is the rate of PCR? So the primary outcome actually in this study is breast cancer event-free survival, and patients are being randomized to the standard of care Keynote 522 versus a regimen which some people call NeoPACT, essentially a doxorubicin or anthracycline sparing regimen. So this is a good option for patients, especially who would consider not receiving doxorubicin, given the concerns and potential side effects from that drug. This is going to see if we're able to achieve the same outcome with a less toxic regimen. And this is currently open at our center. All right. Now we are going to transition over to the metastatic setting, and we'll talk about the HER2 positive space first. So this trial, the PATINA trial, was recently published at San Antonio, the big breast cancer conference in December. And what it was looking at was metastatic hormone receptor positive patients as well as HER2 positive patients, so what we kind of commonly call triple positive. And importantly, these patients did not have progression of disease after their standard of care induction chemotherapy with or without, or I should say with Herceptin, with or without pertuzumab. And so what we're doing kind of before PATINA was that we would do induction chemo, continue the HER2-directed therapy, add in endocrine therapy for these patients, and continue on. Okay, so what this study was looking at was, can we improve upon Herceptin and endocrine therapy in the maintenance phase by adding a CDK4/6 inhibitor, one that we haven't talked about today called palbociclib or Ibrance? Can that improve long-term outcomes? Specifically, can it delay progression? And the primary endpoint was progression-free survival. And what we are seeing was about a delta of 15 months between the arm that received palbociclib versus the arm that did not. There are some higher rates of toxicity, but they are pretty consistent to what we see with palbociclib, like fatigue and neutropenia. And so given this efficacy and the known tolerability, adding palbociclib or Ibrance to this patient population, we certainly should consider in 2025. Okay. So next, we'll talk about an update in metastatic hormone receptor positive patients. This is a study called INNOVO 120 that was published last year. And so thinking about the patient population that is studied on the INNOVO 120 trial, that's important to highlight. So this is a patient population that is had essentially metastatic recurrence, so a history of early stage hormone receptor positive breast cancer, now with a metastatic recurrence, in addition to a PIK3CA mutation. So that's an important caveat. And this patient population had to be higher risk, so they either had to relapse while taking their adjuvant endocrine therapy or within 12 months of stopping endocrine therapy. Also important to note is that patients were not included on the study if they had an A1C greater than 6% due to the known side effects of inavolisib. They were randomized in a 1-to-1 fashion to include inavolisib plus standard of care fulvestrant and palbociclib, and they were continued until progression or unacceptable toxicity. And so looking here at the progression-free survival, so they reported on progression-free survival at a median follow-up of 21 months. And you can see here that at the median progression-free survival with inavolisib on the inavolisib arm was around 15 months versus 7.3 months on the standard of care arm. So essentially a statistically significant benefit of around 7.7 months. And just to kind of highlight also when thinking about this group of patients on this study is that this was a poor prognostic group of patients. If you look at the standard arm, their median progression-free survival was really only about 7 months, which is much less than we're used to seeing in the first-line setting when utilizing a CDK4/6 inhibitor. We typically see PFS greater than 20 months. So this is certainly a high-risk population that was included on the study. And I would say one other thing is that originally when this was published in 2024, the overall survival data was immature at that time, but final overall survival data was presented in an abstract this month at ASCO and also published just recently in the New England Journal, and it showed a 7-month absolute benefit in overall survival. Toxicity from inavolisib, so things to consider, and we do have experience with other PIK3CA inhibitors, alpelisib in metastatic breast cancer. So these are some toxicities and side effects that we are used to seeing. Certainly stomatitis, hyperglycemia, and diarrhea. Important to note that exclusion criteria of patients with elevated A1C. They did not see any grade 3 or 4 episodes of rash, which we sometimes see in PIK3CA inhibitors. And the discontinuation rate on the study was around 6%, 6.8% in patients on inavolisib. And so I would say, just to kind of conclude this study, this is a triplet combination of fulvestrant, palbociclib, and inavolisib, and it certainly should be considered in patients who do meet the trial criteria for INAVO 120. And this also highlights another important test when considering inavolisib. So all these patients had to have PIK3CA mutations, and so typically in the metastatic breast cancer setting, the timing at which we get next generation sequencing can be quite variable. But this does highlight the importance of getting early next generation sequencing to really find out which patients do have the PIK3CA mutations and therefore would be eligible for inavolisib. And then to also highlight a trial that we have open here at UNC in Chapel Hill for patients with metastatic hormone receptor positive breast cancer. This is the PUMA study. It is a novel phase 2 trial, and patients are eligible if they have had disease progression on 2 lines of endocrine therapy. And it is utilizing an oral aurora kinase inhibitor, so a novel agent called alisertib. So this is a really good option for patients who have already been through the standard of care endocrine therapy options and are looking for another all-oral, still non-chemotherapy treatment. So this is a phase 2 trial that is open here. Okay, so next we are going to pivot to another topic. This is specifically antibody-drug conjugates. So the next 3 trials that we'll discuss are all related to patients who have developed endocrine resistance and have moved on to other systemic therapy, specifically here ADCs. And what we'll just want to briefly highlight, what are ADCs and what they consist of. But an ADC has 3 components. So there's an antibody component, there is the chemotherapy or cytotoxic payload, and then a linker that binds both the antibody and the chemotherapy. We're currently in 3rd generation of ADCs, and improvements have been made with each of these generations in each of the 3 components of an ADC, which by improving that has improved the efficacy as well as reducing the off-target side effects. So the first step of an ADC is that the antibody has to bind to its target on the tumor cell, and then the complex is internalized and the chemotherapy is released, killing the cell. Some of the payloads in ADCs are semi-permeable, and so they're able to diffuse into neighboring cells, and this is called the bystander effect. And this process allows the treatment to be more effective, given the heterogeneity in cancer cells, all of the cancer cells may not express the target in an equal way. And so this is still allows the drug to have a bystander effect, as they say, and potentially kill adjacent cancer cells that may not have the target. So this is a newer study that was published in the Destiny Breast series of studies. Previously, Destiny Breast 04 was a landmark big trial that led to the approval of an ADC called TDXD, or trastuzumab deruxtecan, also known as Enhertu, the brand name. And this was approved for hormone receptor positive, what we call also HER2 low metastatic breast cancer after one line of chemotherapy. So this study also included a small cohort of triple negative HER2 low patients. So the Destiny Breast 06 is a follow-up to that study. It was presented last year's ASCO and now has been published in the New England Journal. So in contrast to DB04, this is a larger study. It is studying only hormone receptor positive HER2 low patients, and also included another subset of patients as we call HER2 ultra low. So patients who are less positive when thinking about low versus ultra low. So it included a cohort in that group as well. Also of note, this was prior to patients receiving any chemotherapy, so they just had to progress on at least one line of endocrine therapy to be eligible, randomized to TDXD versus physician's choice chemotherapy. And you can see here that there was an absolute benefit of around 5 months, and this was specifically in the HER2 low population. And we saw a similar result in the overall intention to treat population and this HER2 ultra low population. Currently, to date, the overall survival data does remain immature. Adverse events were similar to previous TDXD trials. So important things to note about TDXD. So nausea, certainly an important side effect that can be severe on TDXD. So we do institute a 3-drug pre-medication regimen. And I've also had some success in clinic adding olanzapine as another drug after their infusion for a few days after chemotherapy, which can help if delayed nausea becomes a problem. The other thing to note is ILD, so interstitial lung disease, a known side effect of TDXD, was seen in about 11% of patients on this study, mostly grade 2. And then in terms of discontinuation rates were around 14% due to adverse events. In my practice, I have utilized TDXD as the next line of treatment in, following the Destiny Breast 06 population, but it is very patient specific. So I do still consider sometimes utilizing chemotherapy after endocrine therapy, especially in a patient, let's say, who has had a very long progression-free interval, may only have bone disease, and is not ready for an infusional treatment. Sometimes we'll use something like capecitabine after endocrine therapy instead of going to TDXD immediately. And then this is a new ADC trial. So the Tropion Breast 01 study is looking at an ADC called datopotamab deruxtecan, or Dato-DXd. This has been approved recently as of January 2025 for metastatic hormone receptor positive breast cancer based on this the Tropion Breast 01 study. So patients in this population in this trial were hormone receptor positive, HER2 negative. They had had 1 to 2 lines of chemotherapy before randomizing to Dato-DXd versus chemotherapy. And just a quick thing about Dato-DXd is that this is a TROP2 targeting ADC. So instead of HER2, this is a different target that the antibody is targeting, but the deruxtecan part, which represents the payload or the cytotoxic, is the same as TDXD. So the median progression-free survival was 6.9 versus 4.9 months. So there was an absolute benefit of two months on this study. And also important to highlight, there has not been a demonstrated overall survival benefit from Dato-DXd, and there may be some reasons for that. Important side effects to think about Dato-DXd. Most common side effects, nausea, stomatitis, so somewhat unique to this drug compared to what we've seen with our other ADCs. We do recommend using dexamethasone mouthwash as prophylaxis to help reduce the incidence of stomatitis, which has been successful in other cancer treatments that have a high incidence of stomatitis. Other unique aspect of this drug is that it does have about, or I should say, a significant number of patients with ocular toxicity. Fortunately, most of these were dry eye, over 50% of cases, and it was not common to have to discontinue therapy because of it. Also important to note, there is a low risk of ILD, so all grade around 3% in contrast to TDXD, which was around 11%. So I will review this in a little while, again, this slide, so I'll skip over it right now. But just to highlight, there are 3 ADCs approved for metastatic breast cancer, and one here that we haven't talked about yet, which we will, called sacituzumab. So next, I would like to highlight the use of an ADC in a real-world case. This is a patient of mine, and she's 34. She has a history of de novo PD-L1 negative metastatic breast cancer that had progressed on single-agent paclitaxel, and her most recent biopsy was ER negative, PR negative, HER2 2+, FISH negative, so HER2 low. Which of the following treatments would you choose for the second-line therapy? So would you choose sacituzumab govitecan, which is an ADC? Would you choose Doxil? Would you choose TDXD? Would you choose oral capecitabine? Or would you choose Dato-DXd? Good, okay. So we have about 80%, over 80% of patients or people saying TDXD. Okay. So, and I did want to highlight for that patient, either would be considered standard of care. She's metastatic triple negative, but HER2 low. So sacituzumab would have been an option, as well as TDXD because she's HER2 low. So I did decide, and with talking to her, we did decide to go with TDXD. And while she was on TDXD, she presented essentially with acute onset progressive dyspnea with exertion. I think we can skip over just her, this is her cancer history, but in terms of the case, triple negative metastatic on TDXD coming to the ER with progressive dyspnea. On admission, she was requiring oxygen to maintain her saturations, 3 liters of oxygen. You can see here is her CT scan on the right. So she has patchy consolidations with ground glass opacities. The differential when thinking about what this could be, certainly infection, always a consideration. Drug-induced, and also considering could this be her cancer. And this was back in August. Also of note, she had a positive viral respiratory panel with rhinovirus, and she did not improve with supportive care over 4 days. So pulmonology was consulted. They had considered a bronchoscopy, but ultimately decided not to do that when talking with the patient. She was started on prednisone 1 milligram per kilogram per day with symptomatic improvement. This was empirically done for the potential that this could be drug-induced from TDXD. And that was the consensus after the hospitalization, given her course, given the repeat imaging with resolution of the changes. And the consideration was that this is most likely related to the TDXD pneumonitis. So I would like to talk a little bit about that, specifically the incidence of it, how we screen for it, and the management as well. So the Destiny Breast 06 study had about 11% incidence of ILD. You can see here, this is a pooled analysis of older studies, and the incidence was higher, and partly this may be due to the fact that they were a more heavily pretreated population, had about a median of 4 lines of chemo prior to TDXD, also included other cancers outside of breast. The median time to onset of ILD was around 5 months. And on that study, about 87% or so of patients had their first event of ILD within the first 12 months. So we are seeing most all cases within the first months of being on TDXD. And then just to highlight the grading of ILD, so important kind of distinctions to make is that grade 1 is radiographic change only. Grade 2 are minimal symptoms. Grade 3 are severe symptoms that typically require oxygen and hospitalization. And some red flag symptoms from pneumonitis include cough, dyspnea or fever, and also asymptomatic infiltrates on CT. And it's important, just want to highlight that it's important to identify the asymptomatic patients, the grade 1 toxicities, so that they could potentially be rechallenged with TDXD. In terms of how we screen, so on study, patients were screened for ILD every 6 weeks with high-resolution CT chest. I would say in clinical practice, there is more variability in terms of how frequently we are screening. I do consider kind of baseline respiratory symptoms and other risk factors. Here on the right was from that pooled analysis study looking at potential risk factors for ILD, such as baseline renal function, baseline oxygen status, and the dose of TDXD. So if there are other risk factors or baseline respiratory symptoms, I am more likely to screen more frequently with a CT scan. And I typically go with about every 9 weeks, but that can be influenced by each patient individual factor. And so important in terms of the management is that any grade of ILD, the treatment should be interrupted. For grade 2, so symptomatic ILD, the standard is treating with steroids with slow taper. And I will say that for patients who are asymptomatic or grade 1, it's also common to use 0.5 milligram per kilogram per day. But there is certainly variability there, but there is sometimes a role for steroids even in asymptomatic patients. Anyone with grade 2 or higher TDXD-related pneumonitis, there is an indication to stop and not rechallenge patients. Within the grade 1 space, there is an opportunity to rechallenge, and that does appear potentially safe. And there was at ASCO an abstract specifically about this in a real-world population. When evaluating pneumonitis, also important to involve pulmonary early on, given the fact that there are potential multiple diagnoses that could explain radiographic findings, but should have a very high suspicion whenever seeing a patient on TDXD with respiratory symptoms. And then briefly, I do want to touch on sacituzumab govitecan, which is that third ADC that we hadn't discussed. This is a TROP2 ADC, so like Dato-DXd. It carries a payload that is also a topoisomerase 1 inhibitor, SN38, a derivative of irinotecan. Important considerations from toxicity include neutropenia. And one of the things that is done with this drug, since it's given on a day 1 and day 8 schedule, is considering either prophylaxis with growth factor or using secondary prevention after someone has experienced neutropenia. It is FDA approved in metastatic triple-negative breast cancer based on the ASCENT trial, and then also in the metastatic hormone receptor-positive metastatic patients based on the TROPiCS-02 trial. So this is a very important and significant area of research currently, and that is looking at resistance patterns to ADC and also sequencing. So this is key to kind of better understand how best to sequence multiple ADCs that have different combinations of targets and cytotoxic payloads, and we currently have just very limited data and information on how best to sequence these drugs, and that will become an issue even more as we go forward as more ADCs come online. So this figure, I won't go through it, but it just highlights the many different mechanisms of resistance that can happen with ADCs. Resistance to both the antibody and the payload can occur, and there are some upcoming prospective studies that may help in the long term for us to figure out how best to sequence ADCs. This is a highlight of a study that we hope to have open here in September called the TRADE-DXD study. And what it is a crossover study. So patients are eligible who are HER2 low, so they can be hormone receptor positive or triple negative as long as they're HER2 low, and they would receive TDXD or Dato-DXD and then cross over to the other drug. And also, this is going to hopefully help us know how to better understand sequencing of two ADCs that have different targets but the same payload. And then the other nice thing about this study is that if patients had received one of the drugs as standard of care, they can enter the study at the ADC2 mark and receive the opposite ADC that they received under standard of care prior. And so this is a summary slide. So this is my current approach to ADCs and metastatic breast cancer. So when thinking about how to proceed, I always do think about clinical trials as possible. We always think about specific patient factors. What is their burden of disease? What is the schedule, toxicity profile? But I do want to highlight the areas in bold here that for metastatic triple negative breast cancer who are HER2 low, I typically do favor sacituzumab if all things are equal over TDXD, just given the fact that we have overall survival data from the ASCENT trial. And there were relatively few and small numbers, about 60 patients that were included on Destiny Breast 04 that were triple negative. So if all things created equal, I do typically go for sacituzumab over TDXD, but there's not a wrong answer there. And then for those who are metastatic hormone receptor positive, who are HER2 low or ultra low, I certainly go with TDXD based on the Destiny Breast 04 and 06 studies. And then after that, I do think about sacituzumab based on the Tropics 02 study. That was in the Tropics 02 study, patients were pretty heavily pretreated, and based on the strength of the evidence that we have from DB04 and 6, that I will go with TDXD first. And then, the difference, some people have asked me, like the difference between sacituzumab and Dato-DXD. I would say certainly these drugs have never been compared. They are, both TROP2 targeting ADCs. If patients are hormone receptor positive and HER2 zero, and where TDXD is not an option, I would consider sacituzumab versus Dato-DXD. But typically, because our experience is greater with Saci, I would go with that first. But certainly, Dato is approved for those patients as well. And then the last topic I would like to highlight is something that we see quite frequently with patients with breast cancer. I do want to preface this on the get-go that I'm definitely not an expert on this topic. I certainly rely, on discussions with our PCP colleagues and gynecologists to help make shared decision-making with patients in this area. And I will also say that the data in this area are limited and sometimes conflicting, which adds to the challenge in how best to manage patients. So we have another response question here. So a 36-year-old female, she has early stage hormone receptor positive breast cancer. She has undergone local regional therapy, chemotherapy. She has been on Lupron with letrozole for a year and 9 months. She's also on ribociclib. She has been experiencing increased vulvovaginal dryness and irritation over the last 6 months, which has led to dyspareunia. And I do want to even highlight before we get to the answers that there's not necessarily a right or wrong answer here. I'm just very interested to see what people are thinking about this. But, which of the following would be your next step when seeing a patient like this in clinic? Would you say, please start, here are some examples of non-hormonal strategies? Would you refer them to gynecology? Would you recommend vaginal estradiol or vaginal DHEA? Or would you consider switching them to tamoxifen? And again, not a wrong answer here.
Okay. And Dr. Aldrich, while we're waiting for them to share their answers, let them know that we'll now open about 20 seconds. We'll open this up so that folks can share their questions with you. We'll get to as many of those as we can.
Great. And so about 65% of people are saying non-hormonal strategies alone as a trial of things like vaginal moisturizers. Great. So just to highlight here, the symptoms of GSM. So on the left, there's a table here which has kind of three different categories of these symptoms. So you have genital symptoms, urinary symptoms, and sexual symptoms. And we typically see these symptoms develop or worsen when patients are on anti-endocrine therapy. And in these days, in 2025, we know that we are trying to keep patients on these medications, anastrozole or an aromatase inhibitor or tamoxifen, for at least 5 years, and oftentimes even longer now, up to 10 years. So this is, becomes even a greater issue given the duration that we are seeing patients on these medications. And this was just a cross-sectional study that basically compared postmenopausal breast cancer patients on ET, and they were compared to age-matched controls. And we know that 57% of aromatase inhibitor-treated patients and 32% of tamoxifen-treated patients had at least one symptom of vaginal atrophy. So this just highlights how common this problem is. So when thinking about management, so the first-line recommendation for genitourinary symptoms of menopause are typically non-estrogen moisturizers. So there's here, and you can get a great reference on UpToDate that highlights many different ones. And they are the first line, so we recommend using them as much as 3 times a week. And one of the examples of a medication that we will sometimes recommend is called Reverie. That's just a brand name, but it consists of hyaluronic acid, which can be an important and helpful part of moisturization. And then certainly lubrication at the time of any sexual activity. So this is kind of standard recommendations when it comes to non-hormonal treatments. Okay. And then let's move to the next. So second line therapy, so we're thinking about the use of vaginal estrogen. So certainly vaginal estrogen therapy is not an absolute contraindication in patients with a history of hormone receptor positive breast cancer, but should be done after patients have not had success or benefit on non-hormonal based treatments, or if they're presenting with very severe symptoms like recurrent UTIs, for example. To preface, there have not been any large randomized controlled trials of VET in patients with breast cancer that are powered for breast cancer recurrence or death, so data is limited to observational studies. I definitely lean into GYN and sometimes even urogynecology for their expertise. And if we do go ahead with topical vaginal estrogen therapy, we do try to use the lowest dose for the least amount of time. And typically patients will have an improvement in symptoms after utilizing it for about 2 to 4 weeks. Some common examples include estrace. Vagifem is one that I typically will recommend because it's an insert, and rather than a cream, the dose can be a little bit more controlled. And then also vaginal DHEA is a common one that we will recommend. This is a pretty well-known study, a Danish national cohort study from the late 90s and early 2000s, which included postmenopausal patients with early-stage hormone receptor-positive breast cancer. And this was basically a prescription registry data set. They were followed for 10 years. In the overall group on VET, there was no increased risk of recurrence or mortality, but when there was a subgroup analysis done, patients who were on an aromatase inhibitor and VET did have a higher risk of recurrence compared to those who were not. There are a lot of issues with the study. There was no data on the dose or type of VET used, and it's very likely that today we're using lower doses. It also predates more modern therapies like trastuzumab for HER2-positive patients. And then the timing of the recurrence was also not defined in the study. So we do kind of take that with a grain of salt when interpreting that data. This is a more recent cohort study of 49,000 women, and they looked at breast cancer specific mortality rather than recurrence, but it did not find any increased risk of mortality in those who used vaginal estrogen therapy with tamoxifen or with an aromatase inhibitor. And so this is my last slide. This is just my approach to GSM in breast cancer patients. And certainly there are a lot of different approaches that folks have. But when thinking about mild to moderate symptoms, that's the area where we really think about non-hormonal strategies like hyaluronic acid and lubrication. And then if severe, I do refer early to gynecology. It's really helpful to have a baseline objective exam that they can do and follow that over time. And then, sometimes I do do consider switching to tamoxifen from an aromatase inhibitor because of the less potential side effects of GSM with tamoxifen. And if there's really no improvement after 2 months of a non-hormonal strategy, I will think more towards using VET. Typically with tamoxifen, we'll use the vaginal estradiol insert. And then on an aromatase inhibitor, if we're staying on that, I typically will try to use vaginal DHEA. And, the main reasoning for that is that on a study with patients on an aromatase inhibitor, it did not, and using DHEA, it did not raise estradiol levels. And so for patients who are on an aromatase inhibitor, I will typically just start with DHEA. And then when symptoms improve, we think about then tapering the VET and continuing the non-hormonal interventions that we had started prior. Okay.
All right. And if I can borrow back the mouse or keyboard here, we'll go ahead. I know we already have a question. Let's see, that should pop up in just a minute. There we go. What diagnostic tools are currently used to monitor disease progression in patients with early breast cancer who completed standard treatment and they are in remission? Any tumor markers effectively being used for this purpose?
Well, that's certainly a great question, and it's a hot topic. I will say in breast cancer, in cancer in general, in the adjuvant setting. And people have different philosophies on this, not necessarily right or wrong. I would say from, my personal opinion is that in breast cancer in the adjuvant setting, I have not been utilizing circulating tumor DNA regularly, tests like Signatera. I think while we know it can help with prognostic information, we have not seen to date a study showing that it can, change, or I should say improve long-term outcomes by making a switch or a change in what we're doing. But I do expect over time we will get much more data and studies to help us incorporate something like ctDNA.
Great. Thank you so much. I think what I'm going to do, I don't have any other questions yet, so let me go ahead and cover the other slides I need to wrap up, and then we'll go back to our Q&A. And so the good news is if you need a minute or two to submit a question, you've got it if you're quick. I do want to say thank you to North Carolina. Thank you to the UNC Lineberger Cancer Network, what we call the UCRF, or University Cancer Research Fund. We want to thank the team here at the UNC Lineberger Cancer Network, Venio Bore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, Kim Riddick. They all work very hard to make this happen. Thanks to Don Poe for the music.